And in a few minutes, we'll be on air. Okay, hello everyone, and welcome to the 15th Rural Family Medicine Cafe. Our topic for this month is rural curriculum. We'll just start off with an introduction of everyone. Yakubu, would you like to start?
Thank you, Amber. My name is Yakubu. I'm a family physician in North Central Nigeria, specifically in Jos. I am a member of faculty at the College of Medicine, and I also practice as a family physician at its affiliate hospital.
Joy, would you like to go next? Oh, maybe she's still getting her coffee. Sophia, would you like to introduce yourself?
Yes, my name is Sophia, and I'm becoming a GP, general practitioner, in the northern part of Sweden, in Arvidsjaur, a small community. And I have been working 4 years and have 1 year left before I specialize completely.
Joy, would you like to introduce yourself? Maybe not. While she's getting settled. My name is Amber. I'm a final year medical student at Swansea University in the UK. I'm originally from the British Virgin Islands, which is where my interest in rural medicine started. I'm also part of the rural and remote health and medical education track here at Swansea University. And I'm really excited about this cafe because we're talking about rural curriculum. Joy, do you want to introduce yourself to the group now that you got your coffees?
Yes, I have my coffee. Hi, I am Dr. Joy Mugambi. I am a family physician in Kenya. I'm currently the chair AFRI1, and I practice rural medicine, which is quite some fun place to be.
Okay, to start off our discussion, I just want to remind everyone that when you're not speaking, it's useful to put the microphone off so that we don't get background noise when other people are answering the questions. The first question I want to put forward to you guys is, what do you think the aims of a rural curriculum should be? So what do you think students and young doctors should get out of a rural curriculum? Yakubu, do you want to answer first?
Please repeat the question. My internet is a bit poor.
I was asking, what do you think the aims of a rural curriculum should be? So what should students and young doctors get out of a rural curriculum?
I can say something on that. Basically, what is of most interest when working with the rural community is the connection that you have with the rural community, the interactions that you get with a smaller population as compared to the urban setup, and the exposure to raw cases, not cases that have already been assessed and already been treated. This is basically primary health care, where you're the first contact, where you're the person seeing the cases just as they arrive from the community. And that way you build a better relationship with the community.
I totally agree with you, Joy. I think, especially in small rural settings, you get to know people a lot faster because it's so small, but you also get to have quite a rich interaction with them as well. Yakubu, do you want to answer the question? Yakubu? I think we've lost him. Sophia, do you want to share your thoughts?
Yes, I agree. I also work in a rural setting, and when we first meet the patients, we have to build relationships with them, and compared with working in a city when the patients they have a broader they can choose where to go, where to seek care, and where I work they only have our place to come to. So and I think that is also different with the rural communities. And I think that is an aspect that has to be taken into consideration when doing the curriculums for the rural medicine. Yeah.
And one thing I quite like about Swansea University was the fact that they did have a rural and remote health in medical education track, so we call it a RHYME track. The aims of that were mainly to get students exposed to rural settings a lot earlier. So as opposed to having sort of a dedicated elective in a rural setting or waiting until we qualified to have exposure to rural medicine, they encouraged us to get sort of stuck in right from first year up until our final year. So now in my final year, I'm in 4 out of 5 of my placements are in rural settings, and one is an elective in another country. The benefits of that are that, as everyone has said, you get to build an interaction with people. You also get to see what it's like when you don't have, access to an X-rays. You have to really get your clinical skills up to par with what it should be as a medical professional. Yakubu, are you back with us?
Yeah, I'm sorry, I had a bit of a challenge earlier.
That's fine. So we're still on the question of what should be the aims of a rural curriculum. Do you want to share your thoughts?
Um, I think that the aim of every curriculum, irrespective of or not, should be competency-based. So if we're talking about rural and we're talking about people who are the front lines, essentially what you're trying to do is to provide a way that trainees can gain the much needed competences. There's really a need for rural communities to own their physicians, and the essence should be some form of interface between what the community needs and competences that the doctor should have. So that's really what I will talk about, and that's what really I'll love to describe.
Well, that goes perfectly into the next question that I was going to ask, which is what does a rural curriculum look like? So do you want to sort of describe what in your mind you think is the best way that young doctors and medical students can be trained for rural?
Okay, I'll start by commenting on some things that I have noticed around the world. I may not be completely correct, so feel free to correct me where what I say it's not representative. But I've noticed that a number of people are being trained exclusively to practice as family physicians and those. And that means that they can pick a particular sort of competency track, and that means daily comprehensive. In fact, the family medicine trainees are trained to be able to work in a rural setting and in an urban setting. And so you have a curriculum that is all-inclusive of whether you're going to be practicing in an urban setting or a rural setting. And it includes you spending up to like 6 months at 2 different time intervals in a complete rural setting. So that means that the doctor should be very confident and comfortable to be the only caregiver for a long mile to go. I don't think that necessarily means that you can answer every question or address every problem. I just think it's having a principle and a mindset that makes comprehensive care acceptable, something that makes it easy to deal with. But of course, a rural community will let you are able to provide most of the basic healthcare services community will need.
I totally agree with you. One of my ambitious visions of the future for the health of the British Virgin Islands, where I'm originally from, is that actually our public healthcare, although we're not rural in the sense of being, we do have similar challenges that make us rural. My vision is for our public healthcare to not be sort of a poor man's last resort, but actually something that will serve the community. I think that's very important in a rural curriculum to get that message across, because one thing I've noticed in Wales is that the attitude my fellow students have had is that, oh, it's in the middle of nowhere, so therefore it doesn't matter. Actually, it does matter because it has an even greater impact on the lives of the people in that community. So I totally agree with you on that point. Joy, would you like to share your insights?
Thank you, Amber. Basically, how we learn rural family medicine is that during our curriculum, basically, we are in rural setup all through our training. We do 3 months within the university and then get attached to a rural practice where the expectation is that you are expected to at least learn your community through community-oriented primary health care, where you've got to write a number of cases, do a number of home visits, follow up around 11 patients, be able to do their home visits and do their chronic care within the clinic. And that really makes you learn how to build a relationship with them. Alongside that, be able to work with the communities to set up preventive services for the community that you're working with. Learn how to do community diagnosis of illnesses and set up projects which will enable you control whatever you find during your community diagnosis. That way, the students get to learn that diseases are not just what you wait for in the hospital. When you find one patient come in, maybe with malnutrition, remember there is 10 more in the community, and you end up being able to follow them up in the community and set up interventions that would be able to benefit those in the community, not just those coming into the hospital. So basically, that's how our rural practice is set up. Back to you, Amber.
Thank you for that, Joy. I really like that you guys have, well, both you and Yakuba have an extensive amount of time in rural settings. In Swansea, we only have like sort of, in my first year, I had 1 day sort of every other week throughout the year, and then 3 weeks in my third year, and now it's sort of most of the year. I think I would have gained a lot more if it was, one block where I was actually able to integrate into the community, which is such an important part of rural medicine, becoming a familiar face, getting to follow up long-term problems. Because of course, most of what a family physician will deal with are chronic problems. They're problems that you'll see over and over again. So that's one thing I missed, but it's something to feedback for another time. Sophia, do you want to tell us what it's like where you're from?
Yes. If I remember back to when I was studying at the university, we didn't have really, it wasn't something that was needed to be in a rural setting, and you could choose to be in a rural setting when doing the primary health care placement. but I'm originally from a rural community, so this was an interest to me to come and work here again. So I think if the thoughts and the challenges of the rural health care system could be more integrated in the university studies, then maybe we could get more of the a growing interest in rural medicine in Sweden, I think. And I think that the interest is growing here. And now when I'm doing this specializing in general medicine, but also rural medicine, the thing that is different for me is the emergency medicine, and that we have some ambulances, and we have more of the emergency care compared to the cities where the hospital is nearby. And also that is important because we are the first line and have to take care of the patients, even well, from traffic accidents to giving birth, and yeah, you can name it all, and it can happen here. So it's a very broad area and interesting as well. And I think at the university it is good to well, tell the students about it and start to make them think that it exists even here.
Maybe Amber, if I added something about Kenya also, we do have the urban setup training, which is the Aga Khan Hospital and Kenyatta University, which are more urban. They are in Nairobi, but they do have a 6 months period where they do take their students down to the rural practice. Aga Khan takes them to Mombasa, and Kenyatta University has a place nearby which is very rural. And every time the residents come back, they're like, that was our best practice compared to the urban practice. So basically, the students enjoy what they are doing, and they are enjoying the rural practice more than the urban practice. Because I think one thing with rural patients is they are real, and they really have real issues, and they are appreciative of what we do. Back to you, Amber.
I mean, one doctor I met put it absolutely setting reminds you of your humanity. It's so easy when you're going through medical school and sort of, we're overwhelmed with all this information all the time, and we sort of become into diagnosing machines, and we forget that the people that we're treating are actually human, and being in a rural setting brings back that humanity, I think. And I mean, it's the same. Well, it's the same in my experience. Whenever I've gone to a rural practice, I've always felt that I've learned more. I've been able to become a more active member of the team in a rural setting than I have in the urban. Not because the urban setting is not welcoming to students, but just because it's a little bit less busy. Not so quiet that I don't have anything to do, but a little bit less busy. The pace is a little bit slower. I can, fully engross myself in whatever projects are going on. And I have enough time to have a chat with my patients. I don't just rush through them, because in the UK we have a 10-minute time slot for every patient. In an urban setting, it's 10 minutes and that's it. But in the rural setting, you can kind of be a little bit more relaxed, you know. Um, the other question I want to ask is, do you think that it should be mandatory for all students in medical school to have some exposure to rural medicine, even if it's not what their interest is in? Because one thing I found with my experience in rural medicine is that it has enriched the skills that I then apply in an urban setting. Because as I said before, you can't rely on all these other fancy tests that we have. You really do have to just be able to take your time, talk to the patient, get a good history, do a good examination, and then everything else is sort of icing on the cake. So, do you think that all students should have a chance to experience rural medicine? And if so, why?
I think what I would say, Amber, is yes. I think it's a good thing to have experience of rural medicine, because when you look at it, we as family physicians go through internal medicine, go through surgery, go through pediatrics. We generally are generalists, and it's part of the experience going through rural medicine, which is basically primary health care. I don't think if you've not gone through rural medicine, you've really had a touch of family medicine. So I think it's really an important aspect. And maybe Yakubu can enlighten us more, because he keeps saying he wishes he would have done more of COPC, which is community oriented primary health care. And maybe we can hear his view on that.
Yeah, thank you, Joy. It's important because of describing what someone has to do and what someone does not have to do. Especially if you say, or if we agree that training in medicine should be learned. So there's this argument that the learner should drive the direction of what he or she wants to learn. Having said that, I will argue in favor of making rural medicine or a rural experience and a necessary part of every medical student's training, and I'll explain why. Because of the unique lifestyles that we have in urban areas, then of the human health experience. So I, I will argue and perhaps say, use the word necessity, shy away from saying tree, but I will say it is necessary.
Thank you for sharing that. That's really interesting. I like the distinction between making it mandatory and
Yeah,
making it necessary. Um,
yeah,
because I totally
yeah.
agree with you. I think if you have students who maybe aren't aware of their interest in rural medicine, it's a way to awaken it without making them feel like, they're under a medical dictatorship where they have to go to rural. It's sort of telling them,
Mm-hmm,
this is important for your training. This is important for your growth as a doctor and as a medical professional. So I really like the
mm-hmm,
phrase necessary. I really
mm-hmm.
like that. Sophia, do you want
Yeah.
to share your thoughts with us?
Yes, I also think that if all students have placements in a rural medicine healthcare system, I think they can have a better understanding of the often different conditions that we have, and that the distances to the hospitals, often it's a long distance, and my experience is that not everyone, most of the physicians that I meet in the hospitals, they don't really have that picture of how far away we are, and that is something that affects the patient care, I think, and so I think it is important, um, uh, also in the medical students training at the university.
Yeah, Amber.
Yes.
Yeah. Um, I thought that there was a second reason I would like to share about why I will say being in the having a rural experience is a necessity for the medical students. We live in a time where the issue of equity has become more like the watchword of everybody who is involved in population health globally. Everybody who is really interested in improving health outcomes of a population and to appreciate what you're talking about if he or she has never had a rural experience. Um, so that's another idea of wanting the medical student to have a rural experience. You need him or her to understand the issues of equity. You have to understand the unique experiences that come about by considering social determinants. And these things over. The third thing I will argue for is the issue of values. That it's not just about the knowledge or being able to appreciate the early stages of diseases or the real unique experiences of illnesses or just equity, but even the values that we teach people. The values are born out of human contact and human interaction. And you broaden the value base of a medical student when you enrich his or her learning experiences. And I think that's these are the reasons that I will argue in favor of making the rural experience a necessity for the medical students.
Thank you very much for sharing that. That was very insightful. Um, One thing I really resonate with is when you said that it brings out the values, that human contact brings out the values. Because, well, on Friday, I had an exam that we take in the UK called the Situational Judgment Test. And this test is worth 50% of your application for your postgraduate training as a foundation doctor. And the entire test is essentially testing, exactly as you said, your values. What would you do if you were in this situation working with a teammate who is having problems coping with stress? What would you do with a patient who says that they would like to die at home? Things like that. And one thing I found I relied on was my exposure to those situations in clinical practice. So, one thing we were encouraged to do was to look at the General Medical Council's advice on what to do in these situations. But I always thought, if I was in that situation, what would I want done for myself or my teammate or my loved one? So I totally agree with you that values the importance of human contact, because it's only through experience that we learn these things. And rural medicine certainly brings them out a lot more than if you were in the hospital. Not so much passions, but have someone with it, more experience. To join the rural track, even if they aren't interested in rural medicine, purely for the purposes of exposure. But there have been issues such as transport and reliable internet connection, which in Café we are no stranger to. So I just wanted to get all of your opinions on what you think the challenges of having students in a rural curriculum will be.
I think that the very first place to sort out is to agree that medical education, whether it's undergraduate or it's postgraduate, is becoming student-centered and trainer-centered. So I think that the first challenge will be the person in question realizing the need, because you can make anybody do a rotation anywhere, and anybody can do anything because he or she wants to pass an exam, and that robs off the essence of what the experience should be. So that ability to see the need, to see the relevance, will be, for me, I would describe as the first challenge. And of course, you realize that we deal with certain unique experiences that wherever you are, any part of the world, it's unique for being in a rural setting, being away from your normal support group, especially for medical students who are not originally from a rural setting. So taking supplements, being the isolation experience, dealing with cultural shock into a setting that is different from accustomed to. And then in some settings, you look about issues if you're going to remote areas that do not really have the structures of governance, including law enforcement officers. A number of people will be worried about the issues of safety. I don't think this is an all-exhaustive list, but I think these are things that anybody will be concerned about. But for me, in my own experience, one of the things that I have been worried about is that teaching experience. We've talked about learning, but who really mentors when my residents go out into the rural posts? Because you don't really have so many teachers who are set to help navigate this experience with students. I will say the first thing is seeing relevance and seeing the need, and alongside other things I've mentioned, having those teachers that embody or embrace what this unique experience should help students navigate this.
I do apologize. My internet kicked me off, so I missed quite a bit of what you said. um, but yeah, Joy, would you like to comment on what Yakubu said, because I didn't hear it? Sorry.
Thanks, Amber. Sorry for the internet. So basically, what I would say, having gone through an experience of rural training, I'd say the biggest challenge I faced was housing. The second challenge was schooling for my children, and moving them to rural from urban having to compromise quite a lot of living conditions. The other challenge probably you face in the rural setup is supplies and training, as Yakubu said. Lucky enough, we weren't very far from our training institution at one point, but at one point I was also quite far from the training institution, but in a facility where there was quite a lot of family physicians. So the training was good. As you move on, you find some areas may not have enough people to train you in terms of family medicine, and there is the movement where the trainers also want to look for better grounds, and so you end up finding you're left with no one to train you, and you're in the rural area, and really not many people want to come to the rural facilities. Other issues, water, the basic things that face the rural people, face you when you're training in the rural areas, which are basically in terms of environment, of living conditions, quite a number of things. So one more thing I would say, Yakubu, I think the rural setup is much more safer than the urban setup, because in the rural area, I could walk from my house at any hour and walk into the hospital. Most folks know you, and you feel more secure when you're in the village than when I'm in the urban area, where I have to lock the gates, lock the doors, and do everything I can in terms of security. So basically, I think for me, the setup of rural is much more safer than urban. I don't know about the other setups.
Yeah, Joy, I understand what you're saying, and I think to a large extent I will agree with you. Um, Unfortunately for me, practicing area, and we have had unfortunate experiences with groups and some other violent groups who find it more convenient to be in remote settings that have poor governance structures. So most likely you will have more of the law enforcement officers in the urban setting and the semi-urban setting. And as you go a bit out into the remote areas, you won't have that. So that has really discouraged quite a number of people from going for oversight functions, taking care of residents. And it has been a big issue that has really at its peak. It was a big concern sending our residents out to the remote areas, to the rural areas, because we had a lot of influx even in the urban areas. But on a general term, where you have not had the evolution of such challenges of security, I agree with you that to a large extent, one will expect the rural setting to be much safer um, for the medical students.
Or maybe also setups in countries make a big difference. Um, I basically feel there's a difference when it comes to countries. So I understand, Yakubu.
Just a comment on what you said, Joy, about having different setups in each country. In Wales, Wales is split up into different they're called deaneries, so they cover a different area that has a main hospital, a certain number of family practices, and so on. And there was one area that I was going to in my second year of medical school that was sort of in the mountains, and they had had students before, but it didn't really work. But they wanted to have students again, So I went there and I told them, this is what I want to get out of it, and had a really enjoyable time. But just as you said, you encounter the same problems that the people who live in that community encounter. You know, the nearest place is like 45 minutes driving from the other. The supermarket is very limited. If you want to get, something unique, you have to go somewhere else to find it. It's another drive and so on. And I made the mistake of going in winter, so there was ice on the roads and the roads didn't have a railing and all of this kind of confusion. But through that, I totally understood when I referred a patient to somewhere else what they were going through. You know, in winter, the sun sets at 4 o'clock in the afternoon. Making a 5 o'clock appointment is not good for someone who lives up a very steep mountain where you need to see it's covered in ice or whatever. And as a student, I obviously wasn't expected to make those decisions on my own. I was provided with support from the practitioner I was with, and got to talk through everything, got to talk to the patients to find out what it was like living there for them. It was a pediatric placement, so I got to talk to, the parents of children with quite complicated conditions. How do they manage when the nearest specialist center is like, 3 hours driving through the snow from where they live? And I got to gain a lot from that. It was the only challenge I did have was um the practice I was at didn't have any wireless internet connection. They had a reasonable internet connection via computer, but the phrase when in Rome do as the Romans do. There wasn't any wireless internet, so I couldn't use the resources I had online, but I was able to access the library and read through books, and everything was fine. I didn't have any issue with it. Sophia, do you want to share your views on this?
I understand that there are different kinds of problems, and we have similarities and we have differences. But I think that one important thing is the instructor or the mentors that the students get, that they really have to have the support when coming to the rural setting, and because it can be quite tough sometimes, and so you need a good support, I think. Yeah.
The next question I want to put forward to you guys, and Joy mentioned it about having an instructor and then the instructor leaving. Um, Obviously, having a good rural placement for students and young doctors relies on having people who are willing to facilitate these placements and willing to instruct us. So, what sort of support do you think is needed for those people to be able to function?
Amber, I would say basically the support I have seen them needing is one, better housing. Two would be better pay. Pay has been an issue because there's discrepancy in my country where if you're working in the rural areas, you get less pay than those working in urban areas, which urban areas are quite congested, and that discrepancy makes most people not want to move to the rural areas where housing will be a problem, the pay will be less, amenities will be few. So if there were better pay, better amenities, better working facilities, maybe internet access, and capacity building in terms of training. Most people feel once you move to rural and keep practicing the same practice, you don't get updated in terms of new updates, new um, techniques that come in. And most people feel once you stay in rural, that's the end of you. So they want to move up to urban and learn new techniques, new health knowledge, and be able to upgrade themselves.
Yeah, I agree with Joy absolutely that we have to enable the instructors or teach that make them feel less. We really do need to invest in making them less isolated. Um, to a large extent, apart from that personal isolation and that apparent lack of professional growth, I feel possible pride about the quality of life his or her family is going to have in a rural setting. I think Joy mentioned that um, going to a rural setting with your family and kids and the need to go to school and there are certain behaviors the child should have. So there are quite a number of things an individual who is grown up can take and you can feel that you can weather the storm. Um, but I think that when a family physician worries about what school his child is going to go to and what amenities or quality of life the child is going to have, it's going to make it very difficult for such a person to stay. So we can't look at health service provision system that addresses the basic comfort that any human being wants. Most likely that when you address certain levels of comfort and sort of safety. I
Yakubu,
also
I
agree
can't
with
hear
Joy.
you.
Okay. I was just talking about being at the basic needs, comfort, basic social amenities, and making the care delivery system part of your provision of social amenities for a particular. That's really one way to keep people. And a second way is making the community own the process. So it's much easier when the community owns the process of having a teacher in a setting.
Sophia, do you want to add your thoughts?
Yes, I agree with the social amenities that is important, and especially if you are not familiar with the area that you are going to. And I think the social interactions are very important to make you feel welcome to that new place and make you feel less isolated in that area. So I agree with that, that it is important.
And just for me to add my 2 cents on the issue, the island that I live on has been called the graveyard of ambition. Precisely as Joy said, because people feel that once you go there, that's the end of it. You're stuck there forever. Whatever dreams you have will now die and you should just bury them along with your hopes and dreams. But I actually look at it from a different point of view. It is difficult living there. I'm not going to lie. It's not as convenient as living in the capital. And as you've pointed out, there is a discrepancy in pay. So doctors who work on the island that I live on only get paid for their hours during the day, whereas the ones who work in the capital can work in their practices during the day and also in the hospital at night doing on calls. So you do earn less, but I like to think of it instead of a graveyard of ambition as a blank canvas. And maybe this is me being naive because I don't have a family and I haven't started working in it. But I often think that there is room for me to create something that wasn't there before. And as Yakubu said, having a community um, that is interested and drives, the medical education of the people there is so important, especially because the point of having someone in a rural setting is to cater to the needs of the community. And if you don't have a dialogue with the community to find out what they need, then it's almost pointless. You're almost doomed to fail. But you've all pointed out some very good issues and also ideas of how to improve things. The next thing I want to talk about is how do we get universities to add a rural curriculum? At the moment, the university I'm at, the rural curriculum is optional. So you can choose to do it, but it's in no means compulsory. But at some point, you may get a rural placement. So it's sort of up to a lottery whether or not you get experience in rural. But every student is expected to at least do one placement in rural. Um, so I just know what ideas did you have about how we can convince universities to add a rural curriculum into the already busy curriculum? Um, I don't know, Yakubu, would you like to start off with what you think we can do?
Yeah, I think that the arguments should be made for that every institution, especially every um, medical college or every medical university, must be socially responsible. You cannot train or produce knowledge or advance knowledge without thinking about your social responsibilities. That's the first thing. The second thing is that you must be ready to be held accountable. So knowing that you should be responsible and knowing that you must be held accountable makes you realize that, hey, you need to accommodate the needs who are new. So how does that translate to rural medicine and rural the curriculum? We have to see, and we have to let school presidents understand that you cannot run a university in isolation of social responsibilities and social accountability, that you cannot ignore the issues of equity when you are advancing. That is one side of the coin. The second side of the coin is for communities to own their, it may seem a bit far-fetched because of the issues of resources. But when you own something, the chances that you are able to influence what goes into it, and it's possible to start from somewhere.
Sophia, as someone who's currently in training to be a GP in a rural setting, do you want to add sort of what you think that we could do to convince universities to take rural seriously?
We have the problem that we have a lack of GPs and at the same time an ongoing urbanization, and I think those can be two things can be arguments to the universities that well, to add the rural curriculum to be maybe not be optional as it is today, but more, well, something that you have to do. And well, maybe it isn't the best way because there will always be some persons that, well, they don't want to go to a rural setting, and they don't have any interest in that. But maybe it can open up some, or maybe increase the interest in rural medicine in a, well, looking at it as a whole. So I think those two, the lack of GPs and also lack of GPs in rural settings, and the urbanization, and also at the same time people growing older and getting more and more diseases, and especially in the rural areas, it is something that is a challenge for the future. So it's good to start early in the universities.
Joy, would you like to add something as well?
Thank you, Amber. And thank you, Yakubu and Sophia. It's true. Thank you, Yakubu, for stating that equity will be more achieved if the universities can add rural medicine. I feel for any other university that's developing a curriculum, I would like it to look at it as a model to add in rural medicine within its curriculum, not as an option, but as a necessity, as Dr. Yakubu said. Let it be added within the curriculum. We go through it as a curriculum. There are blocks within the ones training in urban as a curriculum. They don't take it as an option. It's part of the training. So if it's part of the training, once you're through with your 3 to 4 year training period, you know what you want to do at the end of your training. You're either taking urban training track or a rural training track, or you're basically going into something else in family medicine, but you've already picked out what you want to do once you're through with your training career. So in summary, I would say let the ones starting out a curriculum include it within their curriculum.
Just leading on from that, I want to ask one last question for this session this evening, or day, or afternoon, or wherever it is where you are in the world. Um, what do you think the rural curriculum should consist of? So, do you think it should be modules where students learn about common conditions or late presentations of conditions in a rural setting, and sort of learn about community-oriented health and management of conditions? Or do you think it should be more practical, where students just get to be involved in the practices that they're attached to, and then maybe do some projects, as Joy and Yakubu said, about following chronic conditions or writing up cases?
Well, again, in answering that question, I will want to ask another question. Why do we have curriculum? Um, so if I'm able to answer why we have curriculums, then perhaps it's easier for me to answer the question what a rural curriculum should consist of. So in part of the things I mentioned earlier is that community ownership process. My argument will be that a rural curriculum should empower the medical students to meet most of the needs or most of the common needs of that setting. So there has to be an interchange between what I know is good for theoretical knowledge and what I know is necessary for competence-based, right? So I will say that the rural curriculum should be more competency-oriented. Um, and this may differ depending on what setting the person is working in. But most likely, if rural settings do not have much access to healthcare. So certainly I will really think a rural curriculum will suggest competences that enables the students to provide a comprehensive set of healthcare. And that can range from being able to take deliveries, to being able to make sutures, to being able to set intravenous lines. So they have to be practical competences. But that's not all. I think that they also have to be values that are embedded in the teaching process. So while I will argue for practical competences that meet the needs of the community, I will also argue for values, systems and character traits, modeling them there in the community and expecting them from the students.
Joy, would you like to add your thoughts?
Yakubu has summarized it adequately. The only thing I would say is yes, being in the practice and yes, being in the community is of more value than just having a curriculum, but being in the community, doing focused work which is based on the curriculum, having projects that once they leave, they have made an impact and they can be remembered for what they did in the community. And if they ever come back to that community, they can be able to see the impact of their projects. It's really necessary within the rural family medicine training. Back to you, Amber.
Thank you, Joy. And one thing I'd like to add, sort of, it's an informal skill, but certainly in a rural setting, being able to be a leader and an advocate for the community that you're working with is very important, because oftentimes you will have to, you have to be the one to strengthen the patient who is frightened or worried. You are the only one that they can come in contact with, and you have a sort of leadership ability to own what you know and what you don't know. And since World AIDS Day was on the 1st December, I was just wondering what your thoughts were on done through experience.
I lost you on that, Amber.
Say again?
I didn't get you on
What did
what
you
you
say, Joy?
asked. I didn't hear your last statement.
Oh, sorry, my internet connection is not working with me tonight. I was saying that one of the things that I learned from being in a rural practice is that you have to learn how to be a leader. You have to learn how to be an advocate of the community that you're working in. And since December 1st was World AIDS Day, that kind of reminded me of, that sort of advocacy in public health in rural settings, especially when there's a stigma against HIV/AIDS. So how do you think that being an advocate or being a leader can be taught in a rural curriculum?
Basically, it begins with the trainer. The trainer should be an advocate within the community because while you're
Being
working with a small, oops,
Yeah. And the natural response will be to look beyond your needs and look to take over. So while I will say I expect certain character traits, and I will want to communicate that to medical students when they go to the rural setting, I will not want to be too rigid. Character traits will be acquired, because this is a real setting, like we've said before. And the rural setting itself will always provide challenges that they can learn from. But what I maybe really expect to happen, or rather what I will be more rigid about, is engaging in feedback, um, asking the medical student to describe his experiences, and just keeping track of what he or she is learning. Think something is missing, I may want, but it's the rural setting is provides a lot of opportunity for informal learning.
Amber, what I would add to that is to be a good advocate, you have to know your community, you have to understand their culture and their context, You can't just move into a community and decide to advocate when you don't know their culture, when you don't know their context, because that would bring a lot of conflicts. So basically, to be a good advocate meets the criteria Dr. Yakubu is talking about. And in addition, you have to first learn your community and the context and how you get to advocate. Like the community I work with really looks highly upon the men. I, as a female, cannot advocate for some male issues. So I basically have to look for the elders who are male and ask them to be able to assist me in advocacy matters. And I would not be on the forefront. I would pass my message and make it contextual, culturally acceptable, and then they would pass it on to the community in an acceptable manner, in a healthy way. And that is more appreciated than me standing there and saying, I'm an advocate, I'm here to advocate for this and that. Really, that would not be contextual and it wouldn't be respectful for the rural community. Back to you, Amber.
Thank you, Joy, and that's a very useful insight on how to get messages across. I mean, in the Caribbean, there's still some generations that will listen to me, especially because I'm younger. But it's kind of like, oh yes, that's very nice. These young people these days, but totally, I can totally see how, as you say, contextualizing your advocacy, making sure that it's in a way that's culturally appropriate and acceptable, will actually achieve the aim of being an advocate. Sophia, can you just add a bit about what you think about a rural curriculum, and especially as a trainee, have you gotten anything in particular that has helped you in your rural practice?
I think what has helped me most has been, well, the advices that I have got from my instructors in, well, growing as a doctor and making difficult decisions and also individual decisions or going out of the box, thinking out of the box, and that has been of most value to me, I think, and also time for reflection. Especially when it comes to more difficult decision making.
Yeah, I would like to add something. Well, probably not really add something, but sort of glean from what everyone has said. That a rural curriculum should really empower the medical students on the art of learning, because he or she is really going to be a decision maker, or in some cases, maybe the only one. That ability to reflect, like Sophia has said, it's a skill that we can't assume the medical students will have. I really like what Joy said, that we need to be sensitive, that we need to be tolerant. Um, but the art of learning helps you know mistakes in a community, and it helps you take on quickly and know the rules of the game. Being innovative means meeting the needs of this community in a way that is culturally acceptable. These are traits, or rather, these are skills, soft skills, if you may say, that we need to actively teach medical students. The art of, um, communication is very, very important. because that's one area, the subtleness of communication and the language, appropriateness of language use. So as much as I will want to teach a medical student the clinical skills, I think the medical student needs social skills to be able to be effective and leave impact in the rural setting.
I totally agree with you. And reflection is one of the things that my university is quite passionate about. We're encouraged to reflect at least every 2 weeks, regardless of what placement we're on, because they're expecting us to learn something, whether it's medical or sociological or something about ourselves. And I think my medical school is quite revolutionary in the fact that they've um, understood the value of reflection. As you said, reflecting is one of the most important parts. It's what helps you grow as a physician in the end. Well, thank you very much, all of you, for sharing your ideas and your stories. This has been quite an enjoyable cafe. So if we can have closing comments from everybody, Joy, would you like to start?
Thank you. Amber, I think one thing I want to learn more is how to reflect. That was introduced once to us, but really, I keep saying I think it doesn't work out for us Africans because we tend to want to close the chapter as fast as possible and not go looking back at it. But it's an art which can really help in healthcare and improve. Though in terms of now the curriculum that we were talking about, the rural health curriculum, I look forward to having more people take part in rural medicine because it helps you learn the communities that you're working with. It helps you learn about the inequities of not just healthcare, social care in terms of distribution of resources. And it also helps you grow yourself in terms of understanding different cultures. So rural medicine is worth as a curriculum. Thank you, Amber.
Thank you very much, Joy. Yakubu, would you like to add your final comment? Yakubu?
Yeah, sorry, my mic was off. To the medical students, I will say that having a rural experience is necessary, not just in clinical skills, but as a person. To the policymaker, university president, I'll say that we have a social responsibility to be in tune with the communities around us. We cannot ignore the issue of equity and
Your mic is off. While we wait for him to come back, Sophia, would you like to add your final thoughts?
Yes, it has been very interesting listening to all of you, and I also think it is a very important subject to discuss. So, and it needs um, interest and also to work in these kinds of questions towards the universities and also other instances like the hospitals as well. So I thank you all for sharing, and it was very interesting to hear.
Thank you so much. Thank you so much for this time. It's been an interesting time to engage and be reminded of the need for a rural experience as part of the training of our medical students. My parting words will still remain the issue of health equity, being socially responsible and accountable to our communities makes this something from. Thank you.
Thank you all so much for your time. It's been a really enjoyable rural cafe. We've talked a lot about not just the rural curriculum, but a lot of the things that make medical education enriched by rural experience. Our next cafe will be on the topic of research in rural medicine, and I really hope that all of you can also join us for that one next month and share your stories and your experiences with us. Thank you so much for participating and spending time with us, and hopefully we'll see you soon. All right, bye-bye, everyone.
Bye, Amber. Thank you. That was nice hosting.
Bye.
Thank you and bye-bye.